Okay, take two here on chapter 19, diabetic emergencies, altered mental status. Not really sure what happened the first time around, why the sound didn't record. Apologize for that. Alright, so topics as always, we'll cover the pathophysiology of it all, the assessment of a patient with an altered mental status, diabetic issues, and other causes of an altered mental status. So the pathophys part. Normal consciousness is regulated by a series of neurologic circuits in the brain that comprise the reticular activating system, RAS. Now, that's responsible for your normal functions of staying awake, paying attention, sleeping, all of that. It keeps a person alert and oriented, okay? So they're conscious, alert, and oriented times 4. They know what's going on, right? So the requirements for all that to function properly in the brain. We talked about this in these cells, right? Oxygen needed to perfuse the brain tissue. Glucose, which is your source of energy to nourish the brain tissue, and water to keep it hydrated. Those three things are extremely important. They're necessary for everything to function properly. So causes of the altered mental status can be deficiencies in oxygen. They're hypoxic. Those three things that we just talked about: oxygen, glucose, water. You have any deficiencies in those, you're going to become altered. You need those for everything to function properly. Trauma, especially head trauma, can cause an altered mental status. Infection. You guys will notice in your careers, elderly patients with a UTI, that infection just changes the entire dynamic of how they act. They can be confused, they can be extremely combative, they can get mean as hell, just downright assholes. And it's all caused by a UTI. You fix that issue and they're back to normal. Chemical toxins harming brain tissue. These can be over-the-counter medications, chemicals used in jobs, street drugs, etc. Any primary brain problems such as a stroke, okay? Stroke obviously affects it. They become hypoxic and it affects parts of the brain. And problem with another system, such as hypoxia due to asthma. Again, anything that is going to cause issues with the oxygen, glucose, or water is going to affect the mental status. So with the assessment, patients with an altered mental status can be dangerous to responders, okay? They're very confused. They're not sure what's going on. They're not acting appropriately. They can be extremely combative. And a lot of times they're anxious and scared. So always consider your safety and your team before approaching the patient. That's with any call. Use law enforcement when necessary. If the scene's unsafe because of that altered mental status, get somebody there that can restrain the patient if necessary. So hypoxia is one of the most common causes of an altered mental status. Remember, oxygen, glucose, water. So if you're not getting enough oxygen, it's depriving the brain of the O2 that's needed to function properly. It can become very confused. Now, in a normal environment, 21% oxygen with air, right? Confusion can start to happen right at 19% oxygen. So keep that in mind. Always consider the possibility of an airway and or a breathing problem, which would cause hypoxia. As always, identify and treat life-threatening problems. Consider O2 administration, titrate to effect, right? You want to keep them at 95% or above. A little bit different with COPD patients. Be alert to the need for positioning and suctioning if the patient requires it, or if the mental status worsens. And the reason for this, when their mental status declines, a lot of times their muscles will relax. They're not able to maintain their own airway. You may have to suction them or sometimes ventilate them. Determine the baseline mental status for the patient. Now, patients with previous strokes, at times dementia, Alzheimer's, even traumatic brain injuries, they can be confused all the time, have an altered mental status. So it's important to know what is normal for the patient. What's their baseline? Thoroughly examine patient exhibiting new or unusual behavior. If they're altered and they're not normal, you need to figure out why, what is causing it, and try to treat that underlying issue. Even slightly altered mental status indicates a serious underlying issue. People should not be confused, all right? There's definitely something going on, and we need to intervene. So the body systems exam and complete history may reveal info about the suspected cause of the altered mental status. Interview family members, bystanders, anybody that's on the scene to try to get the baseline mental status. Now, in a nursing home, you need to take that with a grain of salt. There's times their paperwork will say that they have Alzheimer's, dementia, whatever, which will tell you they normally have an altered mental status. And nurses, CNAs, whatever, they'll tell you, oh yeah, they're normally with it, they're normally walking around, whatever. Yeah, it just seems like nursing homes, you don't get a whole lot of great information there. Family may provide info patient is unable to give, especially if they're altered. They can't answer questions appropriately. Rely on the family as much as possible. Patients' medicines may point to relevant medical history. This is where recognizing some of the common medications out there and what they're for will definitely help you during your assessment. If their medications are there and available, grab those and look through them. If you don't recognize the medication, there's plenty of apps out there for your smartphones to where you can look it up on what it's for. Medical alert bracelets or other health-related items at scene. You don't see a whole lot of medical alert bracelets anymore, but sometimes they are out there, maybe alerting you that the patient is allergic to something, diabetic, which is a lot of cause of altered mental status. You may be able to tell that. So with peds, they may not be able to answer questions in the same manner as adults. We all know that. And therefore, the mental status is often difficult to establish. Typically, with kids, you want to go with the family. Remember the oxygen, glucose, water. Maybe they've been sick lately and thrown up diarrhea, which is going to dehydrate them, possibly make them confused. It's going to affect their glucose. They may have asthma, which would, affect the oxygen. Talk to family. They should be able to tell you a lot about what's going on with the patient and what's normal for them. Ask parents or the caregivers, are they acting differently than normal? And this is especially true in toddlers and infants. So think about it. What kind of info about a patient's altered mental status might you obtain from the scene? A lot of different things. When you show up on scene, you may be able to determine if it was a possible trauma. You can look for medications for, diabetics, which may alert you to it's a diabetic issue. There's a lot that you can obtain. How might bystanders help you identify the cause of an altered mental status? If they're family, they'll probably have a lot of information. If you're out in public, bystanders sometimes will be able to tell you how they were acting prior to, or what's been going on, alert you if there was any trauma or anything like that. So diabetics. Glucose is a form of sugar. It's a basic source of energy for the body. We've talked about this with the cells, remember? These cells require glucose to remain alive and create energy. So glucose, it's a large molecule. It will not pass into the cell without insulin. And this is where diabetics have the issues. Okay, so insulin is created in the pancreas, and it goes into the bloodstream, the blood sugar, helps break it down and take it over into the cell. Again, produced by pancreas, binds to receptor sites on the cells, and it allows the large glucose molecule to pass into the cells. Sugar intake insulin production balance allows body to use glucose effectively as an energy source. Now, with diabetes, there's two types, right? We got type 1, and that's where the pancreatic cells do not function properly. There's some type of issue with the pancreas. Insulin is not secreted normally as it should be. So there's not enough insulin in the body. So that transferring of the glucose into the cells is just not happening. That's where diabetics take those shots of insulin. It's a synthetic insulin, typically prescribed to supplement the inadequate natural insulin. And by taking those shots, it allows the glucose to reach to the cell to give energy. Now, type 2, the body cells fail to utilize insulin properly. So there's enough insulin, but the cells themselves are not functioning properly. It is just not able to move the glucose into the cells. Now, this condition is often controlled through diet and or oral anti-diabetic medications. This is your metformin, which is a pill diabetics will take. Now, hypoglycemia, remember hypo is low, glycemia, that's your sugar, right? So it's a low blood sugar. A lot of different causes for this. Sometimes diabetics take way too much insulin. They have to monitor what they're eating, where their sugar's at, and then take units of insulin. If they take too much, it's going to drop it dramatically. They don't eat in time. They need to regularly eat to provide that energy, the glucose. They over-exercise or they overexert, which will burn through the energy that they have. Anytime they're sick, they're vomiting, diarrhea, it will affect your sugar. And diabetic increases metabolic rate, fever, or shivering, right? So the signs, it's usually a very rapid onset, may present with abnormal behavior. They're like a drunk person, honestly. So late at night, and sometimes it's hard to tell if it may be a diabetic issue or drunk when you first get there. Always take a blood sugar anytime somebody is altered. Pale, sweaty skin, they're going to be tacky, their heart rate's going up, as well as their breathing rate. Depending on how low it goes, sometimes patients will have seizures. So the results of being hypoglycemic is starving the brain cells. Remember, it needs oxygen, glucose, and water. They're not getting that glucose. It's starving the brain cells. So it's not the brain's not acting properly. You're going to have an altered mental status, very altered at times. Depending on where they're at, can be unconscious and can cause permanent brain damage. Real quick with the hypoglycemia, they can get very low very quickly. We also have to be aware our interventions only last for so long. Okay, we need to get them to eat. Hyperglycemia, high blood sugar, right? Hyper's high, causes decrease in insulin. Can be because of the body's inability to produce insulin in the first place. Can exist because insulin injections not given in sufficient quantity. Causes can be stress, increasing dietary intake, they're eating too much or eating the wrong foods. You'll see a lot of diabetics, they just don't take care of themselves. Signs develops over days, weeks. They're going to have a chronic thirst, they're going to be very thirsty, some bit hungry. Increased urination, they are constantly urinating, which can be a sign, especially with people that don't know that they're diabetic. They're going to be nauseous, sometimes with vomiting. They're going to have profound dehydration, and water affects the brain, right? So they're going to be confused. Excessive waste products released into the system. And diabetic ketoacidosis, DKA, which is a very serious condition. Profound altered mental status. They're going to be in shock caused by dehydration, hypovolemic. Rapid breathing, and sometimes, but not always, an acetone odor on the breath. It's a very fruity smell. I'll be honest with you, in my career, had a lot of DKA patients. I don't always have, can't smell that fruity smell on their breath, okay? As always, with the assessment, ensure scene safety. Perform your primary assessment. Identify the altered mental status. Perform your secondary assessment, history of the present episode, what's going on, just like any other call, right? You want to know how it occurred, time, duration, any other symptoms, what's going on. You can use your sample history, that's always good. Determine the history of the diabetes. Question patient or bystanders if the patient's extremely confused. Look for the bracelet. Look in the refrigerator or elsewhere for medications such as insulin. They have to be refrigerated. Look for that metformin. Sometimes patients will be on an insulin pump, or nowadays you will see patients, diabetic patients, they'll have that little reading. I don't really know what it's called, but it's a needle that goes into their arm, and they can use this other device that will constantly read their blood sugar, and that's typically in their upper arm. It's just a little circled or square deal that's stuck into their arm. Perform blood glucose monitoring if local protocols permit you to do so. Honestly, check a blood sugar on every call, regardless if they say they're diabetic or not. It's a very cheap and effective way to determine what's going on, and a lot of places just consider it a vital sign anymore. So your blood glucose meters, your glucometers, measure amount of glucose in the bloodstream. Patients typically have these at home. Pretty much everywhere uses them by EMTs. Follow your local protocol. So here's your assessment. You can see she's getting her glucometer ready. So less than 60 is asymptomatic, and symptomatic diabetics is considered hypoglycemia. Less than 50 is significant alterations in mental status. That's not always the case. I've had calls where diabetics are at a 28. They're not confused at all. They may be a little bit slow, but they are completely with it. With diabetics, a lot of it depends on where they typically run. If they're normally running low, they've gotten used to it, and they can get pretty low before any signs or symptoms are there. Like I said, 28 and they were fully with it, and then I've had patients that were at 45 that were unconscious. So it all depends. Greater than 140, considered hyperglycemic. Greater than 300 for a prolonged time. That's when the dehydration and other more serious symptoms start to develop. And you'll notice a lot of diabetics will run in the 200s normally. So just think about that. If they're in the 200s normally, and that's where they like to run, they're pretty close to developing symptoms. So sometimes, depending on what the sugar is, may display a word instead of a number. It'll say high or high. Indicates an extremely high level, usually greater than 500. Some glucometers, it'll be 700 depending on the model that you have. Know the limitations of your glucometer and when it will say high or low. Low indicates an extremely low level, often less than 15. Here's a picture of a glucometer. There, bottom left, you're going to have a container full of glucometer strips. Need alcohol preps in there, and your lancets, single-use lancets. Occasionally, you can treat a person with mild hypoglycemia and a minor altered mental status by simply giving them something to eat. Peanut butter sandwich, orange juice, something to get that glucose into their system and let them get better naturally. Never administer food or liquids to the patient at risk for aspiration. They need to be able to control their own airway, need to be able to swallow. Oral glucose. Criteria for this, they need to have a history of being diabetic, altered mental status, awake enough to swallow. This is your hypoglycemia. The patient squeezes a glucose from a tube directly into the mouth, and the EMT can administer glucose using a tongue depressor. Now, this is going by the book, that's going by the national standard. In real life, you don't use those. If you're having to use a tongue depressor to get oral glucose into a patient's mouth, they're not able to protect their own airway good enough. You don't give it. So there you see a patient doing the oral glucose there, squeezing that in. These things taste like shit. Before I ever give it to a patient, that's the first thing I tell them. I'm going to need to give you this and raise your blood sugar. Sorry, it's going to taste like shit. I just give them fair warning. It's horrible tasting. And they need to take the entire tube. Again, this is fast acting, and it's temporary. They need to eat actual food after giving them this. It will raise their blood sugar a little bit, but they still need to eat. Now, some places carry oral glucose that is a liquid. We do here at Kewaunee Fire Department. It's the same as the gel there. They need to be able to protect their airway. It's the same dosage, and they still need to eat afterwards. Alright, so anytime you give a medication, right, we're going to reassess the patient. Did they improve, stay the same, did they get worse? If the condition does not improve with the oral glucose, consult medical direction about whether to administer more. Yeah, if it's not coming up, I will always give more. Just depends on what your local protocols are. So the onset with hyperglycemia has a slower onset, right? While hypoglycemia tends to come on very suddenly. These are the differences. Skin. Hyper patients have warm, red, dry skin. Remember, they're dehydrated. Where hypo patients have a cool, clammy skin. A lot of times they're going to be very diaphoretic. The breath with the hyperglycemic patient typically has that acetone, that fruity smell, but they definitely do not all exhibit that sign. One thing to be aware of with diabetics before we move on here, elderly patients don't always check their blood sugar. And it's not because they don't want to take care of their diabetes. It's that they can't afford it. That stuff is not cheap. I have gone to many patients. I've asked them when they check their sugar last. Usually, diabetics check it in the morning, afternoon, and at night. And they will tell me it's been a few days because they're out of glucometer strips and they can't afford more. Their insurance won't pick up for another few days. These patients are definitely at risk of, becoming a hypo or a hyperglycemic. They need that reading to tell how many units of insulin to give themselves. So you guys will run into that quite a bit. So other causes of altered mental status. Sepsis. You're going to run into this a lot in your careers, becoming more and more. It's a collection of problems associated with the response to infection. It occurs when steps normally taken to fight infection move from the local site and become a systematic problem. It's actually entered the bloodstream. If severe enough, the microbes of the offending infection can release toxins that harm cardiac output. So with the severe sepsis, you're going to have altered mental status. Their heart rate's going to be up. They're going to be very tachy. Excuse me. Their respiratory rate is up. They're going to have a low blood pressure. Their sugar is going to be high. And they're going to have a decreased capillary refill. Another thing with these patients is they're going to have a temp. They're going to be running a temp. Part of the body's way of fighting an infection, right? They're going to be very hot to the touch. Another thing that you can do is put them on capnography by nasal cannula. And what that's reading is the expelling of the carbon dioxide. Now, they're going to be breathing fast, right? So normally the number should be high. In sepsis patients, because of what's going on inside the body, you're going to have a reading on your capnography of 25 or lower. Really, if it's below 30, I definitely suspect sepsis. Normal range for capnography is 35 to 45. Seizure disorders. If normal brain function is upset by injury, infection, or disease, the brain's electrical activity can become irregular. This irregularity can bring about a seizure, sudden change in sensation, behavior, or movement. Seizure is a sign of an underlying defect, injury, or disease. So two main types of seizures, you have your partial and your generalized. Partial affects only one part or one side of the brain. Patient may not lose consciousness during these times. Generalized, it affects the entire brain and affects consciousness of the patient. They'll be completely out of it. You have tonic-clonic seizures. They will definitely be unconscious and major motor activities. These are your typical, the entire body shaking, right? The tonic phase, the body is rigid up to 30 seconds. This is before the shaking actually begins. You just kind of tense up. The clonic phase, their body jerks violently for 1 to 2 minutes. After that, they're going to have a postictal phase. So after the seizures actually stop, there's going to be a slow period of regaining consciousness. Maybe a while before they start to wake up, and when they do, they're going to be very confused. Most of the time, they won't know that they had a seizure. Sometimes they can't recognize their own family members. They're just very out of it. Some seizures are preceded by an aura. It's a sensation a patient has before the seizure actually comes on. It could be a smell, a sound, or just a general feeling right before the seizure. And these patients that get these, they know one's about to come on, and they will prepare themselves for that. So causes, hypoxia, strokes, traumatic brain injuries, injuries to the head, toxins, hypoglycemia. Can be from brain tumors, brain defects, infection, metabolic issues, and idiopathic. Epilepsy, which is probably the most common, everybody knows about. Certain diseases such as measles and mumps, eclampsia, and heat stroke. So during the assessment, what were they doing before the seizure started? Was there something that caused a seizure, or are they epileptic? What did they do during the seizure? This is important so we can tell what kind of a seizure it was. Was their entire body shaking? Did they fall? What was going on? Did they vomit? Which tells us there may be some aspiration. How long did the seizure last? This is also extremely important. Hopefully there's bystanders that can tell you that. And what did they do after the seizure? How postictal were they? Did they come to it right away, etc.? So if you are present when a seizure occurs, help the patient to the floor or the ground. This way they don't fall, or if they're in a chair, you don't want them flopping out and possibly causing some trauma. Loosen any restrictive clothing. Remove objects from around the patient that may harm them if they were to bump into it. And protect the patient from injury, but do not try to hold the patient still during the convulsions. Basically, you want to protect their head and make sure they're not bouncing that off the floor. Now, old school, you used to hear to, make sure the patient didn't bite their tongue off. Don't stick your fingers anywhere near a patient's mouth who is seizing. That is a good way to lose your own fingers. So after the seizure, you want to protect the airway. You'll hear a lot of snoring respirations that decrease muscle tone from being hypoxic. If no possibility of spine injury, position the patient on their side in a recovery position. They're cyanotic, ensure open airway, and provide artificial ventilations with supplemental O2. If the patient breathing adequately, may be given O2 by mask or nasal cannula. Treat any injuries the patient may have sustained, and transport the patient. Anytime you have a seizure, you're going to want an ALS unit. We carry medications called Versed that can stop a seizure. Status epilepticus. 2 or more convulsive seizures in a row without regaining full consciousness, or a single seizure lasting more than 10 minutes. These are serious conditions. It's a high priority emergency requiring immediate transport to a hospital, and definitely ALS. Again, any seizure, you should have ALS. The reason this is so dangerous, during a seizure, patients become extremely hypoxic. They're being deprived of that oxygen. On top of that, they're burning through glucose like crazy, right? So when it's more than 10 minutes or they're not regaining consciousness, you're looking at permanent brain damage if it's not intervened quickly. Now, not all seizures present as generalized tonic-clonic. Most of them do. But you do have partial seizures, uncontrolled muscle spasm, or convulsion while the patient is fully alert. They may not be able to talk at that time, but they're fully alert and know what's going on and able to know that they're having a seizure. A complex partial seizure, those are the ones often preceded by an aura. The generalized seizures, tonic-clonic, absence, or a petit mal seizure. It's brief without dramatic motor activity. It's a temporary loss of concentration or awareness. They may go unnoticed by everyone except the patient and knowledgeable members of their family. These are also confused quite often with a TIA, a form of stroke. So going on with stroke, it's a death or injury of brain tissue from oxygen deprivation. It can be caused by a blockage of an artery supplying blood to part of the brain, so it's not getting the oxygen, or bleeding from a ruptured blood vessel in the brain. This also causes a lot of pressure and brain damage from that. So signs, you're going to have one-sided weakness, hemiparesis. That's very common. It's typically going to be your left or right side. The part of the brain that's actually affected will be the opposite. So if you have right-sided weakness, it's the left side of the brain that was affected. You're also going to see facial droop on this on the same side a lot of the times. Difficulty speaking or complete inability to speak. This is where they have the slurred speech, unable to form words, or sometimes they just cannot speak at all. Headache caused by bleeding from the ruptured vessels. A lot of times they will also describe it as some of the worst headaches in their life. It's less common, but very important to know the symptom. They're going to be confused, very altered. They can be dizzy. They may have numbness, weakness, or paralysis. Again, one side of the body. The looser bowel or bladder control. We call this incontinent. You also see that in seizures as well. Impaired vision can be blurred, double vision, and high blood pressure. Difficult respiration or snoring respirations, nausea, vomiting, seizures, unequal pupils. Again, headache, loss of vision in one eye, unconsciousness. Does happen, but it's uncommon. Another sign of a stroke that's not covered here. If you ever show up on the scene and a patient is staring off to one side or the other, and they don't turn to look at you even when talking to them, that's a very good sign of a stroke. They just have this far off stare, staring in one direction. It's a good sign that they're having a stroke. So communicating with a stroke patient can be very difficult, especially when they're confused or they're unable to speak. It's very hard because they can comprehend what's going on, but but they can't talk to you. Reassure the patient as much as possible. Damage to brain can cause partial or complete loss of the ability to use words. Aphasia. It's a general term meaning difficulty in communication. So TIAs, we kind of talked about this. It's small clots temporarily block circulation to part of the brain. Causes stroke-like symptoms, but the difference is these symptoms resolve when clots break up. Complete resolution of symptoms without treatment, usually within 24 hours, but usually much sooner. You will get called for a patient's not acting appropriately, and by the time you get on scene, they are just fine, wanting to refuse. That's typically a TIA. Their symptoms can go away very quickly. So patient assessment. A lot of places use the Cincinnati Stroke Scale or the FAST scale. Stroke patient more likely to show abnormal response. Ask patient to grimace or smile. What you're looking for is that weakness on one side, that paralysis. When they smile, if one side does not go up, that's called a facial droop, right? Sometimes you can see it without them smiling, sometimes you can't. So there you can see a patient kind of has that far off stare. The tongue's to one side, it's kind of lost that muscle tone. It's got that facial droop there. Ask patient to close their eyes and extend arms straight out in front for 10 seconds. So what you do, you raise their arms, they're holding straight out, palms up, and you have them close their eyes. If they have that weakness, it's going to drop just like that. Ask patient to say something. They can say anything you want. And what you're checking for is their ability to form words or slurred speech. So for conscious patients who can maintain their airway, you're going to calm and reassure the patient, especially if they're unable to form words or speak. They still know what's going on. Monitor the airway. With the stroke, with the weakness, you can have decreased muscle tone. They may not be able to protect their airway. Administer high concentration oxygen if it's below 94% or signs of hypoxia. Titrate to effect. Transport emergent to a hospital. For the unconscious patient or patient who cannot maintain the airway for them. Provide high flow O2, transport emergent. So transport suspected stroke patient to a hospital with capabilities for managing a stroke patient. That's where you need to know your area. Capabilities must include a CT scan at minimum. That way they can do a CT of the head and determine if it's a stroke. Okay. Also, as quickly as possible, you need to call a stroke alert to the hospital, to the receiving hospital. This way they have time to get the CT ready. If people are not there, get them in there. Time is of the essence in the case of a stroke. Determine and document the exact time of onset of the symptoms of a stroke. This is extremely important. The medication that hospitals can give to reverse the effects of a stroke, if there's a time limit, okay? So the more info they have about when symptoms started or when they were last seen normal is extremely important. Document contact info if person other than the patient provides time of onset. I typically don't do this. Usually I ask if that person is going to the hospital so that they're there to answer questions, but it's actually a good idea. Dizziness and syncope can indicate serious or life-threatening problems. It may be impossible to diagnose the true cause of a syncopal episode. So dizziness, common term meaning different things to different people. Vertigo, sensation of surroundings and spinning around you. I've had that plenty of times, usually alcohol-induced. Lightheadedness, sensation you're about to pass out, pre-syncopal episode. A lot of different causes of this, dehydration, chemical imbalances in the body, sometimes standing up too fast. So syncope is a brief loss of consciousness with a spontaneous recovery. It's typically pretty short, few seconds, even to a few minutes. Patients often have some warning that a syncopal episode is about to occur. They're dizzy, lightheaded, they're seeing those black spots, I'm sure we've all been there, right? Cardiovascular causes. Bradycardia and tachycardia can cause decreased cardiac output, and if left untreated, can cause a syncopal episode. Vasovagal syncope is thought to be the result of stimulation of the vagus nerve, which signals the heart to slow down. Slows down, decreases cardiac output, syncopal episode. With the vasovagal, this you will run into quite a bit with elderly patients. Typically they have heart issues anyways, or on medications that slow their heart rate to begin with. You will respond to patients that are on the toilet. So as they're trying to shit and they're bearing down, it actually stimulates that vagus nerve, and will cause them to pass out a lot of the time. Interesting to note, a patient that is an SVT, extremely high heart rate, that's a lethal arrhythmia if left untreated. That's how we have patients vagal down, which can sometimes fix the issue. Tell them, bear down like you're taking a shit, just please don't actually shit on my cot. Hypovolemic causes. Low fluid blood volume causing dizziness or syncope, especially when the patient attempts to sit up or stand. You'll have a lot of patients when they stand up very quickly become lightheaded, pass out, or try to sit up from in bed. The source of bleeding may not always be obvious, and it's not always a volume issue. Sometimes people are just hypotensive, all the time, and quickly standing up or whatever will cause their blood pressure to drop quickly. They'll pass out. Metabolic and structural causes, alterations in brain chemistry or structure, can lead to a diminished level of consciousness. Inner and middle ear problems also cause dizziness and syncope. You ever had an ear infection to where your balance is way off and extremely dizzy? And it can happen. Alcohol and drugs can cause fluctuations in consciousness. I've been there. I'm sure everybody has a story of this one time I almost died from drinking whatever. Yeah. Other causes. In half of the cases, no cause is ever found. This is especially true. Once you get out on the street, you may not know what caused it. Always assume it's cardiac until proven otherwise. But even you or the hospital may not find out what the issue is. One of the reasons that's not covered here is behavioral issues. You will see some people with mental and psychological issues have these so-called syncopal episodes. There's really no underlying cause except for whatever has excited them or gotten to them mentally. They just can't handle it, and they just pass out from it. So the assessment, as always, identify any life threats and treat them, your ABCs, right? Gather important info that will assist in overall treatment. Have you ever had any syncopal episodes in the past? Is this normal for you? What do you mean by dizziness? Describe it a little bit. Did you have any warning before passing out? Were you dizzy or lightheaded? When did those symptoms start? How long did it last? How long were they out? And you'll need to get that from bystanders or family if there are witnesses. What position were you in when the episode occurred? This is important to know regarding a fall. Are you on any medication for this kind of problem? It's also important to know, are you on any new medications? Do you have any other signs or symptoms currently? Nausea, vomiting? Have you been sick lately? Did you witness any unpleasant sight or experience a strong emotion? Did you hurt yourself? Did anyone witness involuntary movements of the extremities, such as seizures? So for the care, administer O2 if needed. Titrate to effect. Call for ALS. That's to rule out any cardiac issues. So put them on a cardiac monitor, run a 12 lead. Loosen tight clothing around the neck. Lay them flat. That's book way. Position of comfort is just fine. Treat any associated injuries which may have occurred due to a fall. So is the seizure or syncope a symptom of a larger problem? So a seizure, there's some underlying cause, right? Was it brought on by hypoxia, any toxins, are they epileptic, right? Something has to explain that seizure. Same with the syncopal episode. Something caused that. You shouldn't be losing consciousness for any period of time. Again, with syncope, you may never know what the underlying cause is. So quick chapter review here. Diabetic emergencies are usually caused by poor management of the patient's diabetes. Right? Typically, that's what's going to happen. Diabetic emergencies are often brought about by hypoglycemia or low blood sugar. Chief sign of hypoglycemia is an altered mental status. Whenever a patient has an altered mental status, a history of diabetes and can swallow, administer oral glucose. You know what? Check the sugar always before giving oral glucose. You need to know what it was prior to and after. Seizures may have a number of causes. Assess and treat possible spinal injury, protect the airway, provide O2. Always gather info about the seizure. A stroke is caused when an artery in the brain is blocked or ruptures. Signs and symptoms of stroke commonly include altered mental status, numbness or paralysis on one side, difficulty with speech. Always ensure open airway, give O2, titrate to effect. Determine the exact time of onset of symptoms and transport immediately. Dizziness and syncope, fainting, may have a variety of causes. You may never know what it is, right? In the case of syncope, administer O2 if needed, loosen clothing, and place patient flat with raised legs if there's no reason not to. Treat any injuries and transport. Now, the reason they say lay flat with the raised legs, this is actually one of the ways you can treat for shock, hypovolemic. It forces the blood in the legs to go to the core, raising the blood pressure and hopefully patient not losing consciousness. Also eases the cardiac output. Determine if the patient's altered mental status is being caused by hypoxia. Remember the oxygen, glucose, water, those are the main ones, right? In a patient with a hypoglycemic emergency, determine whether the mental status will allow the administration of oral glucose. Can they protect their airway? Can they swallow? Assess the seizure patient to determine the need for artificial ventilation. They're going to be very confused when they come around. Decreased muscle tone, may not be able to protect their airway. Determine when the symptoms of a stroke began. Extremely important to try to get that information. Alright, let's go on to the critical thinking. So a 62-year-old male is witnessed to have a tonic-clonic seizure. Remember tonic-clonic, right? So for about 30 seconds, he just stiffened up, and then hopefully only 1 to 2 minutes had that violent shaking going on. You find him actively seizing. His skin is pale and moist and slightly cyanotic. Discuss the immediate treatment necessary. At a basic level, what you can do in this situation, you can't give him any medication to stop the seizure. So you need to protect the patient as much as possible. Protect his head. Prevent him from getting any injuries during seizing. You definitely want an ALS unit en route for what they can do, their medications. But you're going to protect the patient from getting hurt. Once the seizing has stopped, place the patient in a position of recovery on their side and protect the airway. You may need to suction. You may need to ventilate, give them oxygen. Okay? Protect the patient, reassure them.